It is May 13th. This is study session 2, and it's about 11 a.m. Give people a little bit of time to get here. So cardiac week started this week, which probably gave you all a heart attack. Find my jokes. Okay, appreciate the smile there, Diana. Appreciate it. How did you feel for the study session on Tuesday? Was that a little bit of a blur? So,
I felt like she explained the lung volumes pretty well. Like
yeah.
Rewatching her video and the recording was helpful.
Good.
So
Good.
I feel good about that. A little bit better about that.
Yeah. One thing I'm going to say that I did see that was a little excessive is not the term I want to use, but a little bit over the top was the placement of the EEG pads or the ECG pads. Don't totally freak out about that. There's not going to be a ton of questions on where all the ECG pads go and what the placement is on them and stuff like that. So I'm like, I saw that, I was like, that's a little much. You guys do have to know like the ST segments, PQSR, all that fun stuff, but you don't have to necessarily know that this pad goes here, this pad, yeah, no, that's right. The only thing you really have to know is if the pads fall off, what should you do? Well, put them back on. Right? And normally the pads aren't going to fall off. What are going to fall off? Because the pads are stuck onto them. What's going to fall off?
The lead.
Yeah, the lead. Yeah. Just the wire. And you just take that, clip it back on. Good. Yeah. Is biomechanics for next week, Riley? Is that what that one's for? Or is that for this week as well? This week. Okay. Yeah, I haven't gotten to the biomechanics video yet. So I've been going through it as well with you guys, just kind of, I want to give them a little bit of pointers here and there. Just because I think it's prudent that if we're paying for it, I should have some feedback into it as well. I do have a Slido for this week for cardio. So we'll see how that goes. Let me find that bad boy here and bring that up.
Mr. McKeever, I had a question. Are we going to have to, on the test, is there going to be any charts that we're going to be having to, like, for the board exam?
I mean, probably the biggest chart you might have is the lung volume. And more importantly, it's not like they're going to put the chart up there and say, what is this here or what is that there? But they'll ask you, what is residual volume? What does inspiratory capacity consist of, right? So those type things, not necessarily like just put the chart up with an A and you have to just find what A is. But yeah, definitely the lung chart is one of those charts that unfortunately we don't get out of. Trying to think if there's any other major charts. I'll think about it. I'm not sure that there are any other major charts that'll go up. I mean, the PQRS wave, yes. Knowing which part is the P wave, which part is that type. That's not necessarily a chart, but that's a diagram kind of. So that one, yeah. And then understanding kind of what's going on with each of them. You don't have to be able to diagnose, and I've got a slide on that coming up. You don't have to necessarily diagnose what's going on with the patient, right? But you have to know specific conditions that are going to change the PQRS wave, right? Like VFib, you should be able to recognize VFib, because what does VFib look like? Does anyone have an idea?
Is it like really fast?
Yeah, it's a sawtooth pattern. It's just going up and down. And I'll bring those up so that you can see them for you guys. Actually, let's start with that before we get to the slide. Let me bring that up real quick.
Sorry, Mr. McCurry, you said what conditions would change on the chart, right?
Yeah, well, so if you walked in and looked at a patient's ECG, you'd have to be able to know what ones might be problematic for you before you'd start treating it. Let me find my ECG one. So if you walked in and looked at, I actually want to keep that one up, save that for later. If you walked in and suddenly you're looking at the patient's ECG, what am I looking at? Is there a problem here? Is there no problem here? Am I good to do exercise? Am I not good to do exercise? Do I have to monitor anything? That type of a thing. So let me bring that up. I found it. Here we go. All right. and this is my simplification of it because again, I'm not the best at these either. So I had to come up with a way to easily remember it. All right, everyone can see the PowerPoint that I have kind of brought up there. Yeah, okay, good.
Yes.
All right, so what we got here is kind of the breakdown of the electrocardiogram. So up here is that EKG, right? You have your P, your PR segment, your QRS statement, ST, T, and then U. What do those mean? Well, the P wave is when the atrium depolarizes. What does that mean is happening? What does depolarization mean? Okay, systole, good, right? So when everything's starting to kind of dump, right, and go down through. And if you look at this, all of them, excuse me, all of them are going to have this segment where they dip below. What is that called when we talked about that on the like the muscle, we call it action potential chart? You remember that one that goes way below normal levels? Because you have depolarization and repolarization, and then at the very bottom you have hyperpolarization. Do you remember that? So hold on, let me bring up, let's go back. Here's where I have somewhere to write. So let's use purple, should show up on here, right? No, purple doesn't show up very well. Red probably will, yeah. Right, so remember with the action potentials, you have your graded potentials, graded potentials, graded potentials, and then it fires off, dips, and then levels back out. Do you remember that from action potential? Right? And so these here were your graded potentials. And really, when you're looking at an EKG, you're just looking at this. Here is your depolarization, right? Depolar. And then as it goes back down, that's your repolarization. Until it drops below until it drops below normal level, that's hyper. Why does it go into hyperpolarization? You remember? That's really bad writing. Do you remember why that exists? Anyone? Any guesses? That's so that the signal can't travel back up the nerve. Remember that? It goes down to that point so that, number one, it can't send another signal immediately, and also so the signal can't kind of backfire. Or not, the backfire is not a good term. Can't turn around and go back the other way, right? You can't do a U-turn. So that keeps it so that nothing can travel at that segment of the nerve. Well, the heart's the same way. The heart needs those depolarization waves, hyperpolarization, and then repolarization type waves. So when you're looking at the EKG, you're just looking at an action potential curve of the heart. It's really all you're doing. So there's not much different between them, except for the fact that one is the heart and one is just a general nerve conduction or even a muscle conduction, right? I'm going to clear this real quick. So that P wave, this first part, is where that atrium depolarizes. Then we have the PR interval. It is a time for the total depolarization. The next area we enter is the QRS wave, or the QRS complex, whichever your book wants to call it, right? The QRS complex is when the ventricle starts depolarization and the atrium starts repolarizing. It gets back to base level. And in that QRS segment, you have the QT interval, which is the ventricle depolarization combined with repolarization. So that just looks at, here's where the QT is, where the ventricle, here's our ventricle depolarization, here's our ventricular repolarization, right? That's that QT interval. And then the ST follows the QRS segment. It's a lack of electrical period. So that's where everything kind of comes back to normal, right? It's where everything kind of settles back in. And then the T wave is where the ventricle goes back to its kind of normal levels. So there's the T wave where it kind of pips back. So you can almost think of those little bumps as graded potentials to kind of get everything back to normal. So you have to know that about the heart. You have to know what normal sinus rhythm is, right? That would be what normal sinus rhythm kind of looks like. That makes sense, right? That's, if you see that on the chart, that's normal sinus rhythm. So bradycardia we know is less than 60, tachycardia greater than 60, or tachycardia should be greater than 100. I don't know why I have 60 or greater than 100. Ignore that. Got to fix that. And then the main thing when we're looking at these, here's another kind of segment on it. There's my disorders, right? So there's a lot of disorders here. The main ones you have to understand are VFib, VTAC. That's where what's happening if we talk about VFib or ventricular tachycardia. What's happening about those? What's going on at the ventricle? So first of all, what does fibrillation mean? Let's go there first.
It's fluttering or not beating correctly.
Yeah, it's fluttering, quivering. Yeah, you just think of it like your eye twitching, right? When you're looking at tests and that eye starts twitching. Well, that's what's going on in either in the atrium with AFib or the ventricle with VFib. If it's fluttering, it can't contract effectively, right? Because it's already using up all its energy to just quiver there. So that means dumping of either the atrium or the ventricle is going to be declined. The atrium is not as important because how does the atrium empty out? Is it by squeezing or is it by pressure?
Isn't it pressure?
By pressure. Yeah. So the atrium fills up, and when it gets to a certain part, that valve opens up and dumps down into the ventricle, right? Now there's a little squeeze there, but you saw it's only this little bump. It's not like a fire off huge action potential, right? It's just enough to kind of gush it. So if you took a sponge and you kind of wrung it out a little bit, that's kind of like what's happening with the atrium, right? The ventricle is going to have that hard push. So the ventricle is why if you're in VFib and that ventricle is just quivering, that's why that's worse than having AFib, right? I have AFib and I'm living a normal life in general. Do I get times where I'm like, oh, that feels weird? Sure, I do, right? But it's not like I'm walking around collapsing every 5 minutes yet. Give me time. That is different than tachycardia. And you're not really ever going to see atrial tachycardia again because the atrium doesn't do an active contraction cycle, right? But if the ventricle goes into ventricular tachycardia, that means that the blood's coming down from the atrium and the ventricle is just going like this, right? It's not fluttering anymore. It just is rapidly opening and closing for no reason. That's going to cause all kinds of problems.
I had a doctor that told me an easy way to see VTAC on a EKG is it looks like coffins.
Yep. Yeah. With VTAC, if we see VTAC, what should we do? That's going to be your question on the board. You see VTAC on the EKG, what should you do?
Hook them up to an AED.
Yeah. Jason, I think she wanted you to repeat that again. She didn't quite hear you.
Oh wait, not coffins, tombstones. I meant tombstones.
Yeah, tombstones.
Like tombstones, yeah.
Yeah. It looks like a bunch of tombstones in a graveyard.
Yeah.
Right? And if you don't take care of it, the patient becomes a tombstone.
Yeah, exactly.
Right? So that's why I've heard that before too. Yeah, yes, AED, call a code, right? Get somebody over there immediately because we're not trained in solving that. We're like, I'll start compressions. That's about all we can do at that point, right? Now, here's a question. Is VTAC a shockable rhythm? What do you think? And this may not be necessarily in your boards, but it's kind of something to know if you're going to work in inpatient. Maybe. Are we going to decide that? No. Right? Either the AED is going to decide it or the doc's going to decide it. But here's something that I laugh when I see this on, like I watch 911 or what's the other show? Chicago Fire. They're like, the patient is in asystole. What's that mean? What's asystole look like? Right? What's going on in the heart at that point? Nothing. There's no contractions going on at all. If there's no contractions, is shocking going to do anything? No. Right? Yeah. So when it's in that I always laugh. They're like, charge 250, shock them. It's still an asystole, right? and you'll find this out if you ever take an advanced kind of heart course, a lot of times when they're in that format, the only thing that's going to help them is atropine. Right. And some of the shows do it really well. Like you see that go into AFib, and the first thing they do is stick the needle in the patient's chest and give them a juice of adrenaline. Right. But yeah, so for you, knowing that VTAC is kind of that repetitive tombstone pattern, VFib just looks like this really weird. If you look at the top there, VFib just looks like it. I don't even know how to describe it. It looks like a mountain range that's completely screwed up. Right. And the main thing with both VFib and VTAC, the easy way you'll know if they're in that is if there's no pulse. Because they can't get an accurate pulse rate when they're in VTAC or VFib. Because everything is just so jacked up. The pulse relies on the atrial contraction, the ventricular contraction to be normal. So that's one thing to remember is those two. Now, all these others here are important, right? Atrial flutter, atrial fib. But for the most part, the one thing you need to know for the boards when it comes to these is you need to understand the segments and you need to understand what VTAC and VFib look like. Does that make sense? So don't totally freak out about this. You know, if you're going to work in a cardiac rehab floor, yeah, you need to know what the difference between an SVT and a STEMI and all that is, right? But guess what? If you're going to that type of a building, you better study, right? I'm just saying, like, if you're going to be working on a cardiac floor, when I transitioned from ortho down to cardiac, I spent about a week going back over my cardiac stuff because I just was rusty in it. And this is one of the things I went back to is studying these things.
Mr. McKeever, do we need to know what the U wave is? I've seen that on some of the ECGs.
Not really. I mean, so let me go back here. Yeah, so we have that little U bump at the end. Is that the one you're talking about? Yeah, you're not going to have to know necessarily that. For the main part, the QRST is what you need to know for your boards. Does that make sense? The U is out there, but what the U is basically graded potential. I mean, don't worry about that too much. And PQRST is what you need to know. No, you don't have to know specific timing. And again, with timing, the problem with, so like this EKG here, the problem with this one is it doesn't have any timing on it anyway, right? The timing is going to be more important for the doctor. So like here, this is important for the doctors to know because they can tell if the ventricle is contracting long enough, if the atrium is contracting long enough. That's not for us. All we have to know is, does it look like it's supposed to look? Does that help out with that a little bit? All right, cool. Let me get out of the stop share here. I thought I found something else I wanted to talk about. What you talking about, Willis? All right, there it is. I want to bring the lung chart up real quick, just so we can kind of look at it real quick. So lung chart, this is it. How Diana says she's feeling better about it, right? That's what she said. So let me kind of go over what a question might look like on your boards about this. So the question on your boards might say, vital capacity is the combination of what parts of the lung chart, right? And so then what you'll have at the bottom is you won't necessarily have the full words written out. You'll have like IRV plus TV plus ERV. And then you have to know what each of those abbreviation means. Does that make sense? And now the good news is that they like make sense. IC is inspiratory capacity, right? RV is residual velocity or volume. So, you know, it might be something, it might say the right one, which is IRV plus TV plus ERV. Then it'll say inspiratory capacity plus functional reserve capacity. Then it'll say TLC, right? You just have to be able to pick which one the combinations are, right? Going over these, let's just quick review them. What is IRV? Inspiratory reserve volume. What does that mean?
It's all the air you can inhale after the tidal volume. So yes. Like what's left over.
Yeah, so tidal volume is what we do normally, right? That's just kind of our in and out normal. So if I take a normal breath in, inspiratory reserve capacity says I can breathe in more, right? Does that make sense? So that's the extra that I could suck in. Why might I use that? Well, if I'm doing diving, something like that, right? Or if I'm playing who can hold a breath longer under the pool with kids and stuff like that, that's when I'm going to use that inspiratory reserve volume. Also, if I'm maybe doing compressions with breathing on a patient, I need that inspiratory reserve volume because I need my tidal volume to breathe, right? If I give them my tidal volume, I'm going to be short of breath. I'm not going to be any good to them. So that's why we give them that extra breath from our own. So tidal volume is normal breathing. Expiratory reserve volume would be the opposite of inspiratory reserve volume, right? So as I breathe out normally, I can then go and breathe more out. What's residual volume?
Air that just sits in the lung?
Yes. Think of it as anatomical dead air, right? What patients have a problem with residual volume?
COPD.
There you go.
COPD.
Yes, good. See how this ties to it, right? Because what happens is that tidal volume kind of shifts up a little bit. The expiratory reserve volume shifts up, and that RV increases. It's normal to have a little bit of air in our lungs, and it's important to have a little bit of normal air in our lungs because that keeps our lungs inflated, right? If we lose residual volume, that's a problem. The lungs are going to collapse because it's a muscle, right? It's just going to suck together. So it's important, but we don't have too much because stale air in our lungs is not actually a good thing. You're not going to be asked about this, but I think they say that you change over residual volume about twice an hour or something like that. So it doesn't just stay in there for the rest of your life. Like I've had this oxygen in me since I was at birth. No, it does change over, right? But it takes a little bit to change over. Inspiratory capacity is the combined tidal volume plus my extra breathing ability, my extra inspiratory reserve volume, right? My functional residual capacity, if you see FRC, that is how much is extra stored in my lungs, right? It's going to be my residual volume plus how much extra I can breathe out. Why is vital capacity important? What does that tell us? Why might we test for that? Or what test might we use to test that? Not us in general, but in medical field.
Like what kind of, like the 6-minute testing thing?
Okay, well, I mean, that'll come into play, but what specific test do we send them down that we're actually going to get these numbers?
Pulmonary function test.
Yes, a PFT, good. There we go, yes, right? Are we going to, so with a PFT, are we going to get blood gases with it? If we're just doing a traditional PFT? No. Right? Traditional PFT is just literally testing this chart. Does that make sense? It's just going to give us our inspiratory capacity, all of the numbers. In order to get blood gases, they have to do what?
Draw blood.
Yeah, they have to have some blood sample. Good, right? They could have a line in that's doing it, right? They could have a central line that's measuring it. But that's not going to be part of the PFT. It may be in addition to the PFT, but it's not going to be part of it. Does that make sense? Or they may do a VO2 max and measure it somehow that way, right? Vital capacity is kind of what we have there, right? It's the total amount we can breathe in versus the total amount we can breathe out. That's what vital capacity is. That's important because that'll tell us if the patient does have COPD, right? If their vital capacity shrunk, but that residual volume's larger, that tells us they have COPD, right? And is COPD obstructive or restrictive?
Obstructive.
Good. Give me a restrictive lung problem.
I can only remember the obstructive ones.
That's fine. That's why I'm going over it.
Everything but obstructive.
Everything but obstructive. I love it. What if I had inelasticity of the chest wall? So my costal muscles, my chest muscles are too tight. That would be a restrictive problem. Does that make sense? What about a rib fracture? That would be a restrictive problem, right? A pneumothorax would be a restrictive problem. right? Anything that's, so basically when I think of obstructive versus restrictive, this is the way my brain goes. Obstructive is in the bronchioles and in the lungs. Restrictive is anything outside of them, like pleuritis, inflammation of the pleura would be restrictive because that's outside and it's causing the lungs to get squished. Does that make sense? Does that help kind of clear that up? Now, what if I had pulmonary edema? Would that be obstructive or restrictive?
Obstructive because it's in the lungs.
Good. Now, what if I had pleural edema?
Restrictive.
Yes. Do you see the difference? I just want to see a couple of my heads nodding. So good. That kind of helps you break down what the difference between the two are. I forgot to have. Yes. Obesity. I'm sorry, Riley. I totally didn't see obesity and pregnancy there. Yes, they potentially could be restrictive. Yes.
And obstructive is when patients are having difficulty breathing out.
Yeah, it could be.
Correct.
Sure. It could be breathing in too, right? If I get stung by a bee, right? And what's that called? What's that reaction called that I have? I get stung by a bee and my throat starts swelling. What's that called?
Anaphylaxis.
Anaphylaxis. There we go. Good. Right. And how do we solve that? What do we give them?
Norepinephrine.
Yes, a shot of steroid, right? Right. Usually in the leg. They should have an EpiPen somewhere. That costs probably $500. Specified the point. We're not going to go into that. Yes. So that in that case, that's still an obstructive, but the problem is getting air in. Does that make sense? Because my throat's closing up. But for the most part, yeah, I would agree with you, Diana. For the most part, it's a lot of getting the air out is the problem with obstructive, right? There's some rare cases that it's, for example, like if you had a paralyzed epiglottis, that might be a restrictive problem that's getting air in and out, right? I do not like cherry vanilla Coke Zero. I'm just going to put that out there. Sorry. Does that help? Kind of clarify that? All right. Let me get out of sharing here. And hello, Miss Brooke. You made it at the exact right time of what I was going to cover. So perfect. I think you were here before, but this is like perfect. Because I believe you were the one that had the question about biphasic versus monophasic. Now, this has nothing to do with the heart, but I want to cover this before we get into the quiz. Let me bring this up real quick. Now, this has nothing to do with the heart, but she did ask this last time, and I didn't have the... That's fine, Brooke. You're okay. It's recorded, so you only missed the first half hour. I only took PPS points away from you. All right. So this is the kind of standard waveform chart when it comes to E-stim, right? And remember, with almost every E-stim out there, if you're putting the intensity down, almost every E-stim, what is the units for the intensity? So like TENS, IFC, Russian, what's the units for the intensity? If you put a intensity at 5, what's your units? Does anyone remember? Milliamps. So almost all of our E-stim is amplitude modulated. Does that make sense? So what that means is do you remember the difference between amplitude and voltage and all that fun stuff? What is amplitude? What's the other term for amplitude? It's not in the past, it's current. Right? Oh God, I know. It's back to physics, right? I see your faces. Hey, look, Brooke asked this question, so blame this one on her. I'm just saying. Right? Do you guys remember what in physics, what the abbreviation for current is? Remember this? Do you remember a little bit about that? I equals V over R. Nope. Pay attention to my physics class, I can see. Oh yeah, there. Thank you, Raquel. It made me feel bad. Just don't remember much about it. That's okay. amplitude is relative to the resistance, right, versus the voltage. Remember, we talked about this. You can have 1,000-volt item and it won't kill you. Because if you get 1,000 volts over 40 minutes, you're not likely to die. But what happens if you get 1,000 volts over 1 second? Then that current is really high and that could kill you, right? So that's when we talked about this. The only reason I cover that is because that explains the actual waveforms, right? There's only one waveform that we typically talk, or two waveforms that we talk about that are voltage regulated, and those are usually direct current waveforms. So like a DC E-stem or VMS, this is voltage modulated stimulation, but you're not gonna have to know VMS for the board. So don't totally forget about that. Monophasic waveforms mean what? If I say a wave is monophasic.
There's just one.
Good, okay. There's just one what? You gotta see her doing it, right? Yes, there's one hump of a wave, whether that's going positive or whether that hump is going negative. Does that make sense? So in this case here at the top one, this is a monophasic waveform. If it is going above the line, is that positive or negative?
Positive.
Yeah, good, right? I could also call a waveform that looked like this monophasic, as long as it stays on one side. Does that make sense? When we talk about biphasic waveforms, now what's happening?
Two waveforms?
It's two waveforms. It's what do I think of it? Right now we're starting to cross the neutral line and then go down to negative. So it's the waveform that's doing the typical sine wave. Does that make sense? So here's a typical biphasic. It's going positive and negative, positive and negative, positive and negative, positive and negative, right? In order to do that, what type of current do you need?
Alternating?
Yes, alternating. Good, right? You have to have an alternating current. So, because it has to be able to go both ways, right? That's the major difference between a monophasic waveform and a biphasic waveform, is the way that the waveform is shaped. The other way is the way it actually causes your muscles to kind of react and the way the signals are sent, but your boards aren't really going to get hardcore into that. They're not going to get into, you know, which muscles react best to a monophasic waveform versus a biphasic waveform. That's you're starting to get electrophysiology there, and that's a little bit. That's here. You got, sorry, I had hiccups. You guys are here, right? If I say that a waveform is monophasic and symmetrical, what does that mean? Any guess?
The same amplitude and lasts for the same amount of time.
Yes. So if I drew another one up here that looked exactly like that other one, that would be monophasic and symmetrical. It means the amplitude and the times are equal. Does that make sense for everybody? So if they're symmetrical, the waves are going to be matching, whether it's biphasic or whether it's monophasic. So anytime you see symmetrical waveforms, that means they are in sync with each other, right? Just like the wonderful band. That means that if they're asymmetrical, what does that mean?
Maybe different amplitudes and times.
Okay, maybe different amplitudes, maybe different times. Typically, if you have both, that's going to be unbalanced asymmetrical, but we're not, again, that's not even, that's beyond you guys. There's not going to be a question on that. The main thing you guys need to be able to differentiate between a monophasic and a biphasic waveform, right? So whether it goes just on one side of the voltage line or whether it goes on both sides, right? That's the difference between monophasic and biphasic. And then if it's symmetrical or non-symmetrical, that's all you really have to worry about when you're talking about the waveforms. Does that help you out a little bit, Brooke?
Yes.
Yeah.
Thank you.
Yeah. So they're not going to say, so they're not going to ask you, your patient is suffering from Bell's palsy, which of the polyphasic waveforms would be best for you to treat? No, that's electrophysiology, right? But they may say you're treating them with a symmetrical biphasic waveform, and then say which of the following waveforms looks like what you would expect from that waveform. Then they'll have the pictures down there, and you have to pick which one is matching. Does that make sense? And so that's how those questions will come about. So I hope that helps a little bit. I just didn't have the right picture brought up last time, or I would have been able to go over that. All right.
Mr. McKeever,
Yes.
I have a question.
Yep.
Can you explain the difference between arteriosclerosis and atherosclerosis again?
Absolutely. Let me get my little whiteboard up here. All right. Can everyone see my whiteboard? Yeah. All right. So I need red. I can't draw an artery in black. That's a bad artery. All right. So here's my artery. During blood pressure, what happens to this artery?
Dilates.
Yeah, it dilates, and then it returns to its original shape, right? So that's happening on both sides of the artery. So it expands and contracts, right? With arteriosclerosis, arterio meaning artery, sclerosis meaning hardening, right? What happens to that artery? It's not able to do what?
Like pump?
Yeah, it's not able, essentially, yeah, you're right. It's not able to pump as well. It's not able to expand and contract as well. So it loses its elasticity, right? So it's not able to spread apart and come back together and spread apart and come back together and spread. So slowly but surely, it kind of just becomes, that area of the artery just becomes kind of a stagnant area, right? So then maybe the area in front of it's pumping, the area after it's pumping, so blood's still getting through. But that area of specific hardening is just kind of sitting there. It's just a highway, right? It's not going anywhere. So that's the first phase of it. Now, when it hardens like that, the next thing that's going to happen, give me colors. The next thing that's going to happen is goop is going to start collecting, because that's what keeps the goop from collecting is the pumping of the artery, right? It keeps pushing the goop and it gets to where it needs to be filtered out. But if that area hardens, think about this from like a stream perspective. If you have a little like stream, so streams are places that water flows, just to let you know for the people that lived in the desert. If you have a stream and that stream has this little kind of beaver dam on it, behind that beaver dam, all this sediment's going to start collecting up, right? And eventually what's going to happen to the downflow stream?
Gets clogged up.
It's going to get clogged up. Good. The same idea with the artery, right? So arteriosclerosis is the beavers building the dam. It stops it from moving, right? Atherosclerosis is what happens after the dam is built, where the gunk starts collecting up in there. And then eventually that gunk is going to get so much that it's going to block the lumen, right? And you'll get down to, you know, most patients will be told, well, you've got a 40% blockage, a 50% blockage, something to that effect. And believe it or not, most arteries, up until you get to about 75, 80% are fine. That's kind of scary when you think about that. We can still pump blood at like 80% blocked, right? But it squeezes through. But again, the more that stays stagnant, the more crap's going to collect there. Does that help? Okay. For just arteriosclerosis, there's not much we can do for it, right? The only thing, there's not much we can, yes, typically, good question, good answer, Brooke. So our atherosclerosis would be secondary to arteriosclerosis. You'd have to have the artery hardening first before you get the buildup. Yeah. And for pure arteriosclerosis, the only thing we can do at that point is modify the modifiable behavior factors. So hopefully it doesn't get worse. Once you get to atherosclerosis, what can they do for it?
A stent.
Okay, that's the last resort. There's one before that they can do.
Medication.
What's that?
Medication.
Start with medication. Good. We start with medication and hopefully break up some of that, right? So they're probably going to put on the statins to kind of clear up the cholesterol in their blood a little bit, because that's what's kind of gathering up there is the cholesterol. The next step they're going to do is an angioplasty. And that's where they're going to stick a tube in. And at the end of the tube, what's at the end of the tube?
A balloon?
A balloon. Yeah. And they're going to go to that area and they're going to expand the balloon. And the idea is the expanding of the balloon is going to push that goop further against the walls. If it's not, you know, if it's like, and I don't quote me on the percentage, but if it's like 60% blocked or under, they usually do in the angioplasty where they just do the balloon. If it's over that, then they go to the stent, right? And the difference between the angioplasty and the stent is with the stent on the outside of this balloon, you have a wire mesh. So when they expand the balloon, the wire mesh has these little hooks in it that go out and grab onto the lumen of the artery. And basically that creates a fencing around the goop. And that keeps that goop in place, but squished further against the walls, which allows blood to flow better. Does that make sense? The downside to stenting is if it's gone into the body and it's a foreign object, that means what could possibly happen?
Infection?
Okay, maybe that. Okay, yeah. But also it could break loose. Right? Maybe those hooks don't grab a hold, right? And suddenly later on, maybe you have a really bad heart attack or something like that that caused a lot of stress in the heart, and it rips that stent off. And now you've got that free-flowing mesh going through your body. That's bad. Right? Now, it doesn't happen often, but that is a side effect of doing stenting. Same thing like if you did a hernia mesh, there's possibility the hernia mesh can come loose and kind of get pieces in your body and stuff like that. But that's the difference between arterial and atherosclerosis. That. All right, let me get out of my whiteboard here. How do I end my whiteboard? Oh, this is new. I didn't know how to end the whiteboard. We'll just share screen. That should stop it. All right, so let me get up our Slido here. I've got 20 more questions and they're cardiac related. So let's see how we do here. You should be able to join it. I'm hoping I did it right. I didn't Dr. Areskin it up. Can you guys see the Slido? Okay, there we go, good. Let's go full screen with it so it doesn't hide things. Dr. Reston's doing great. It's just we changed the computers in the school, or we upgraded the computers, and it's causing her technical issues, and she's not liking it. I'll give you guys a few minutes to get everything up.
Mr. McKeever, where did you say we could find these at?
So I posted the video in my 209 portion of my YouTube channel, and in the description I post the link to the Slido for the day. So like today, after I upload this video, there'll be a link in that actual video that shows where it's at, that you can go to it afterwards. Friday the 13th. Oh God, I forgot it was. That explains a lot when I went up to get the mail. All right, is everyone pretty much joined there? Oh yeah, I don't even want to go into the printer. We're not going to talk about that. All right, take a deep breath. Yes, it is. You're exactly right. It's also the day that if you guys forgot, I made sure I did it last night. I left out milk and cookies for Jason Voorhees. So I wanted to make sure he didn't kill me. All right, let's start the slide and see how it goes. 1, 2, 3, starting it. And again, I did shorten it down to 45 seconds just to kind of get you guys. I know, don't shake your head at me. If you can do it in 45 seconds, you can do it in a minute and 20. Okay. What is that position called?
Tripoding.
Tripod or recovery. Good. Yeah. Right. Pretty much. Here's the deal. If you see that it's talking about that the patient needs to recover from lung, whatever, whether it's short of breath, whatever it is, tripod is pretty much always the answer. Whether it's standing tripod, where they're like this, or whether it's forward leaning tripod, where they're kind of like this. Right. That's pretty much guaranteed to be your answer. Almost 100% of the time. I'll go over that in a second, Raquel. Sorry. Okay, let's see what we got. All right, first of all, to go back to Raquel's question really quick. Recumbent is exactly like Anthony looks driving down the road. That's what recumbent looks like. Leaning back, right? Recumbent is leaning back. That's also known as what position? What's the other term for the, what'd you say?
Semi-Fowlers or semi?
Semi-Fowlers, yeah. There we go, good. All right, so PT's working with the patient with CO, got it, my voice cracked there a little bit. With COPD, which of the following expectations would be likely found? The chest wall is not going to decrease, right? That at that point, that is not an obstructive problem. That is a what type of problem?
Restrictive.
Restrictive. There we go. Good. Yeah, that's a restrictive problem. Now, I'm going to skip the three that are going to skip over the right answer. I'm going to go to the other two. Uneven rise between contralateral sides of the ribs. If you see that on your boards, that's typically indicative of a pneumothorax. That's not indicative of COPD. It's a good kind of hint that that's more pneumothorax related, right? Meaning there's something going on one side, whether they have a puncture, something going on that side. Or they could have a big bubble of air. Right. If you guys ever seen that on like again, going back to 911 or any of the Chicago fire shows where they talk about somebody gets air around their lungs, how do they solve it usually? Stick a needle in and drain the air out around the lungs, and that allows the lung to reinflate, right? If there's uneven rise, there's a problem with one of those lungs not being able to move. And there's a couple different reasons for that. With COPD, respirate actually doesn't decrease. Right? They're still breathing their 12 to 20 breaths per minute, right? But it's just that they're not able to get it out, right? So the ribs are decreased with respiration. They're not able to move as much. That is not because the ribs aren't moving. That's because the lungs aren't moving when they breathe out. Yep. 4-to-1 ratio. Not sure what, are you talking about the difference between rib expansion versus lung expansion? Is that what you're talking about?
I just remember learning something about a patient who has COPD and then their ratio like of breathing is 4-to-1. So that's why I thought the decrease.
Oh, okay. Yes. I'm sorry. Now, yep. Thank you. Now, yeah. So 4-to-1 meaning they breathe in about 4 times as much as they breathe out. So, right. And usually 2-to-1, 3-to-1, 4-to-1 is that our normal ratio is 1-to-1. We breathe in for a second, we breathe out for that. We breathe in for 3 seconds, we breathe out for 3 seconds, right? Yes. Okay, I didn't think what you're talking about. Yep.
So it's saying that there's decreased rib expansion with respiration.
Yeah, that means that the ribs are not moving because the lungs aren't moving as much. Does that make sense?
Okay. I
Yeah.
just, because I'm thinking they have such a like barreled chest already. So I'm thinking like, I don't know.
Right. And if they have a barrel chest, then their ribs are not going to what? Move.
Yeah. Stuck kind of.
Yeah. And that's not, and again, barrel chest definitely doesn't mean, because a patient with COPD does have a barrel chest, right? But that definitely means that chest wall is not decreased, because that would be in. Right. So this would be one where you just kind of have to kind of figure out which one is the best option there.
Okay.
All right. Next one. Here we go. Okay. Give me a second here. I'm just finding Dr. Reskin. Now that you guys mentioned her, it was like you guys summoned her. All right. Why is 1 wrong? Why is higher systolic and diastolic wrong?
Diastolic blood pressure shouldn't change during exercise.
Yeah, diastolic really doesn't change. Good. Why is 2 wrong? There's an easy reason why 2 is wrong.
Is it because it's phase 2 cardiac rehab?
Nope, has nothing to do with that.
The stroke value?
Okay, good. What about it?
I don't know, but now that I'm rereading it, I don't know why I chose that one.
That's you're going the right path there, right? What is stroke volume?
The amount of blood the heart pumps out.
Yeah, the amount of blood the heart pumps out. If the patient's in a cardiac program, what's their stroke volume probably already look like?
Decreased?
Decreased, yeah. Right? So exercise capacity will be reduced due to higher stroke volumes. What should happen to exercise capacity if the stroke volume goes up?
It should also go up.
Yeah, it also goes up. Right? So you as healthy people, you go out and you start running and training for a marathon. Your stroke volume is going to go up. As your stroke volume goes up, you're able to run farther because your heart doesn't have to work as hard to push out as much blood as you need. That means the stroke volume is going up. That means your exercise capacity goes up. The only time exercise capacity should go down is if their capacity goes down, their stroke volume goes down as well, right? And then heart rate will be higher while systolic BP will be lower. Why is that one wrong? Well, because if they're in a cardiac rehab program, their systolic doesn't go lower. I'm just saying, right? If they're in cardiac, that's going higher. So heart rate and BP will be higher. All right, deep breaths. Question number 4. Okay. So overall, pretty good. Those of you that picked long-term prednisone use, why did you pick that?
Because it's steroid, doesn't it destroy your bones?
Good. Yes, the side effects. Yes, good. Guess what? You picked right. If they have reflexive muscle guarding, what are we going to do?
Shake them till they relax.
Shake them till they relax. Yeah. We're going to try to get them to relax, right? And that's expected, especially if you're doing a first rib mob. That's expected to happen because doesn't feel good. It just doesn't. Concurrent inhalation therapy. Why might we do a first rib mob while they're getting concurrent inhalation therapy? So what does inhalation therapy mean? What are they getting? They're getting a breathing treatment, right? Yeah, the mob will help expand the chest wall, right? Good. That mob will actually help that maybe medicine get in further into the lungs too. And then functional chest wall impairments, what is that? Would that be a precaution?
That'd be an indication, right?
Yes, that'd be an indication. Yeah. Good. All right. You guys can't see it, but I got music going on in the background too. That's why my head's bobbing.
Mr. McKeever, I didn't even know they had precautions for the first rib move. I've seen them do it. I've seen them do it in the clinic, and they never even
ask.
So that's why I didn't even know.
It's okay. And with the prednisone therapy, just to let you know, Diana, that's a precaution to any mobilization. Well, it doesn't matter if it's first rib, it doesn't matter if it's spinal, because prednisone weakens the bones. All right, so good. I'm glad that no one picked number one, because I just envision this. Oh my God, your blood pressure is going low. Hold on one second, just stay there. I'm gonna go tell the PT. Down the patient, right? The first thing to do if they become hypotensive is stop the activity and sit them down, right? And you guys remember that, not necessarily mnemonic, but that phrase I taught you to remember?
Red, raise the head, pale, raise the tail.
Good, yes. Red, raise the head, pale, raise the tail. So when they become hypotensive, they're going to become pale. So that means you got to get the legs up. I like the last one. I don't care that you're having a blood pressure issue. Let's just walk farther. Now, if we were to sit them down, raise their legs, and the hypotensive doesn't improve, now that tells us it might be a blood sugar issue. Does that make sense? And then we might have to adjust blood sugar. But the first part is just sit them down before they fall on you. Good, 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 good. Pretty much a good rule of thumb when we're talking about pulse oximetry is anything below 90 is when we notify, and PT, nursing, whoever. Pretty much a good rule of thumb. Okay, so just be aware of that. Now, when we talk about COPD, it may get a little bit lower, but for the most part, a good rule of thumb is if it goes below 90, notify somebody, specifically a PT preferably. What type of patient, talking about this, what specific type of patient is pulse oximetry unreliable? Patients that do what?
Get their nails done.
Okay, if they get their nails done, okay, yeah, that'll be one. Smoke, yes. Yes. People that smoke, the pulse oximetry is not necessarily reliable. And I tend to err on the side of caution with those patients. And I may, you know, in the hospital, this isn't for the boards, but in the hospital, I kind of, it'll be like 92 or higher just to be safe, because the carbon monoxide from smoking bonds just like the carbon, or just like the O2 does. So you have to be careful. Good job, guys. Next one. I'm going to get one of you that's like, what's segmental breathing? Okay, so how many of you guys had no idea what this was? Anyone?
Me.
Yeah. Did you do segmental breathing before?
I'm thinking it's like diaphragmatic breathing.
It's the difference between diaphragmatic breathing, it's the difference between phase 1 and phase 2. So phase 1 is here, right, on the belly. Phase 2 is what?
The lateral rib.
Lateral, right? And then depending upon if you're working other phases, you might actually even work upper expansion too, but that's not part of ACB, right? But segmental is working on that. So let's think about this for a second. Just because if you didn't have an idea, that's okay. I put this question, I put this on here on purpose, right? Let's think about this for a second. If you didn't know what segmental breathing was, how do you stimulate? Let's just take it back to muscles. How do you stimulate a muscle? You put your hand on it and you apply pressure
on it.
Yeah. Right? That's the basics of stimulation. So if I'm having problems with the bicep, I can tap on it. But the main area is I put my hand on it and I give a little bit of pressure, and that's going to trigger the patient to kind of reflexively contract with it. Same idea here with segmental breathing, right? I'm going to put some pressure in the areas I want them to expand, because that tells them where I want them to expand. Does that make sense? So segmental is, I want to do some belly, I want to do some ribs, I want to do some upper chest. And we do this with patients like children with CF, or, you know, people that are having pretty problematic expansion problems with their chest. It's okay. I put that one on there on purpose because I wanted to throw one question I knew you guys would have no idea what it was. That was on there on purpose. All right, next one, 7, 8. This one everyone should get. Okay, good. Most of you got it, right? In that acute phase of heart training, why do we not stress the upper extremities?
And it's more stress on the heart.
Yes. right? Pretty much you're guaranteed if you get a question about this and they're in the acute phase of a heart condition, go down and find anything dealing with the upper extremities, right? So we wouldn't have them do upper extremity bikes, or we wouldn't have them do upper extremity lifting. We wouldn't have them do the UBE, right? We probably wouldn't have them do wall push-ups or anything like that. Does that make sense? So we just avoid the upper extremity. And then the lower extremity exercises, that's when we get into the more kind of matching mets and stuff like that. But the more important thing is just watching that upper extremity. All right, here we go. Question 9. This looks a lot like a previous question, but it's different. Okay, so we're all over the place. All right, so again, no one picked reflexive muscle guarding. Good idea, because they're going to do that anyway. What's percussive therapy mean? What are we doing? Yeah, we're beating on them. Good. Wheezing and shortness of breath. Guess what? That's a
indication.
Indication. Yeah, that's an indication for it. Poor chest wall excursion just means that the chest is not expanding. That, guess what? That also is a indication, right? But if you have functional chest wall immobility, that means that that chest wall isn't moving at all. If you start beating on it, what's probably going to happen?
Start being mobile.
So if my chest can't expand or contract and I start beating on the body, what am I likely to end up doing?
Maybe puncture a lung.
Yeah, I may break a rib and puncture a lung. Yeah, I need the chest to be able to move while I'm doing it. Right? So if I sit here and I kind of start doing progressive therapy on myself, I can feel my chest wall kind of rebounding with the compressions. But if I tighten up and I do the King Kong type chest beating, that hurts. Right? There has to be some functional rebound there. Okay, there is one word in this that answers your question for you. Does anyone know what that word is? Cramps. The muscles are cramping. What should you take if your muscles are cramping? Just in general, not talking about the heart patient, but if you're getting a lot of muscle cramps.
Potassium.
Potassium. Good. So that means if they're having cramps, what's likely to happen in their body? They probably have what? Low potassium. Yeah. What is the proper term for potassium? Kalemia. Right? Because what's the periodic table symbol for potassium?
K.
K, yeah. Right? Natremia is what?
Isn't it blood?
Well, it's in the blood. All of these are in the blood. Emias are all in the blood. So this is saying they have low blood potassium. But natremia is low sodium. Na, right? I tried to invite the sodium for a party, but he said nah, bro. See, remember that joke now. Yes, so that's sodium, right? And then calcemia, you kind of figure out what that is, right? That's calcium. But in general, if it says cramps, start thinking potassium. Does that make sense? That's the key word there. Now, could the patient also have low blood sodium as well? Could they? Yeah, I mean, they may. So we just have to kind of, we start with the easiest and work our way. All right, sorry, I got a text message there, I got distracted. Good, postural drainage. Now, are we going to teach them diaphragmatic breathing? Yeah. Right? What is postural drainage?
You basically put them in a position that drains the mucus out of their lungs.
Good. Yeah. Whichever segment has it in it, right? So the primary focus or the primary treatment for patients with CF is postural drainage, right? All these other things we may teach them, but the primary one is postural drainage. And also percussive therapy, but we don't talk about beating kids in this discussion. I mean, what? All right, let's go for 12. Oh, it's a keyword for calcium. Are you asking when you would worry about calcium? Is that what you're asking, Raquel? Yeah, if they're talking, so Raquel had a good question. Is there a keyword for looking at calcium? Obviously, anything dealing with bones strength, that would be a calcium keyword, right? But when we're talking about cardiac type stuff, that would be mainly dealing with specific heart rhythms. So the calcium is responsible for a lot of our heart rhythm. That's why they're going to put you on calcium channel blockers if you're have some heart rhythm problems. All right, so patients in phase 3 cardiac rehab. So which is the most likely to demonstrate a decrease in which of the following? So should they, if a patient's in cardiac rehab, should they be exhaling carbon dioxide? Yeah. Right. Now, which patient would not exhale carbon dioxide?
COPD.
COPD, yeah. Right. So that would be one we would worry. So that one I would have ruled out automatically because it has nothing to do with cardiac rehab. It has to do with pulmonary rehab. A decrease in which of the following: cardiac output at maximal work. Now we don't pick that one, right? Stroke volume and maximum work. Again, that should be improving as we get through the phases of the rehab, right? So the first one is the right one, heart rate at some max work. What that's basically saying is their heart rate doesn't go super high when they're not doing a lot of stuff, which means they're progressing in their cardiac rehab. I hinted at this one earlier. Okay. First of all, who is taking digoxin? What primary group of patients? Heart failure, yes, but let's not even go there. There's one specific group. I know that Diana was like, I hate medications before, but.
Well, I'm working on it.
That's okay. I hinted at this earlier. I may be on digoxin because I have AFib. It is a primary medication for AFib. Okay. What are the signs that your AFib is out of control?
The heart rate?
Nope,
No.
Doesn't affect heart rate. Now your heart doesn't feel right when somebody checks your heart rate, but it's still beating. Because AFib is just the atrium quivering. Remember, it doesn't really affect the heart rate because it's just dumping. So it's like, yeah, it's bad, but not really bad. Weakness and palpitations. Right, and this is just one. I put this on here on purpose because I knew it was a medication, and we're going to go over all of the medications. Don't worry. I'm not doing that today because we're going to go through all of them. But you need to know about all the medications. We're going to do a day where we just do meds. And what you should look for this med, what you should look for this med. And we're like, I want to do that closer to the boards because that way it sticks in your head a little better, if that makes sense. So I do it now, by the time you get to the boards, it'll be gone.
So I wanted to do flashcards for the medications. Well,
Okay.
For the heart, do you think that's a good idea that I do
That's not a bad
now?
idea. It's not a bad idea, yeah. And then when we go over it, it'll just maybe you'll be better at the heart meds.
Yeah. Okay. So I remember like ACE, the beta blockers, and the calcium one are like the three main ones. Should I be memorizing like the specific name of the medication?
I'm going to give you hints on how to tell what these medications are. Like by looking at their name, you'll be able to tell what they specifically, like all the ones that are like Oxin and Alice are typically AFib meds. So, because like this is digoxin, Lenoxin is another one of it, Ligitalis. Those are pretty much all AFib meds, right?
Okay, because in the video for for that one, he has like, he kind of just narrowed it down to 3 of them, and then he kind of focused on that. So I was just.
Yep.
Okay.
And what I'm just going to do is give you tricks on how to, if you see a medicine you don't know, kind of break down what kind of medication it is. Right. There are ways by looking at this one. Like for me, I look at this and go, oh, it's an Alice or an Oxin. It's an AFib med. Right. But it's an X of some sort. So Lasix, Darasix, stuff like that. That is a diuretic med. So there are certain ways to kind of learn those. So with this one, with AFib, so if they start getting weakness and palpitations, that means that they probably need their meds, right? And that means they're not monitoring it well enough. Slowed heart rate, what meds cause that?
The beta blockers?
Beta blockers, yep. A little bit of, oh, look, you got a friend. I see Riley occasionally has her cat walk across, and so you got a little cat too that came in to visit with you, Jason. Yes, beta blockers, some calcium channel blockers too, right? The slowed heart rate, we're worrying about the heart meds, the congestive heart failure meds, right? Confusion and memory loss, what type of meds? Is it cardiac meds? Not typically.
Painkillers.
Painkillers, good. Muscle relaxers, stuff like that. And then involuntary movement and shakings, again, that's where we get back to the muscle meds, right? It's okay, that's why I put that on here. I do these on purpose. There's a reason for my madness. There's a reason for this one too. I'm gonna get one of you with this. I got some of you. I love it. I got some of you. How did I know I was going to get some of you? Because as soon as I mentioned spinal cord injury, I knew some of you were going to go to hyperreflexia.
So hyperreflexia is when you change the position and you check the catheter?
Hyperreflexia is not hypotension. It's hypertension. Yes, right? Because think about it, hypotension, again, what's colors their face going? Pale. Hyper, it's getting red, right? I put this on here on specific. So this patient basically says every time they change positions going up, they're getting dizzy. Well, that's what we're going to work on. That's reacclimating them to the vertical. We actually want to work on that, right? So I threw this on here on purpose because I knew that as soon as I said C6 spinal cord lesion, you're all like, oh my God, stop and check the catheter. Stop and check the catheter. All right, on a couple more. All right. I am glad that no one picked coughing and producing yellow mucus because that means they have a what?
Infection.
Infection, good, yeah, right? Crackles and cough is common with congestive heart failure. Specifically, what side?
Left.
Left,
Left
good.
side.
Yes, good guess, right? Crackles and barrel chest. Diana, you got this one. Crackles and barrel chest, what condition? Or I think it may have been Brooke. Which one? I don't remember which one of you it was that answered barrel chest earlier.
I think it's Brooke.
Yeah. Barrel chest is
COPD.
COPD. Yeah, there we go, Brooke. Good. Right? Inspiratory wheezing and shortness of breath. What condition are they suffering from there?
Asthma.
Asthma. Yeah, there we go. All right, 16. I don't really like this question now that I read it. Good, most of you got the right answer. Yeah, so the main thing that clues you in here is the shortness of breath and weakness, right? The weakness is cluing you in that blood flow is not happening. That's an MI, right? What would be the signs of unstable angina? They'd be doing what?
Clutching their chest.
Yeah, complaining of pain. Yeah, right. Or I got tingling going up in my jaw, something to that effect. Those would be the angina symptoms. Like I said, I don't like this because I was starting to think that the HTN meds possibly could be there, but the HTN meds, if it just said confused and short of breath, then yeah, that would be more towards the hypertension meds. But because you've got the weakness combined with it, that's more heart related. That one could be a little bit, I could word that one a little bit better. But again, it's the weakness clues you into MI. Okay. We're a little bit all over the place. All right. Humeral fractures, why not? Well, not funny, has nothing to do with this. That one I'd automatically rule out because what does Trendelenburg position look like?
You're in prone and your legs are slightly like 30 degrees elevated, I believe.
Yeah, so either prone or supine, really. Either way, depends upon prone or supine Trendelenburg. Doesn't really matter. But the legs are higher than the head, basically. Yes, right? So humerus, not really a big deal because we can always strap them in if they can't hold on to something for it, right? Claustrophobia, what would that be a precaution for?
Like an MRI.
Okay, MRI, or what treatment do we do that could be claustrophobic causing? Dealing with the spine. Where you're putting straps all over them.
Oh, traction?
Traction, yeah. Right, think about it. If they're claustrophobic and you're strapping them into this machine, they're freaking out, right? Rib fractures, while I would say it'd be important to know, it's not necessarily a precaution or a contraindication for postural drainage. But why would CHF be a precaution?
Because you're just helping the backup of fluid.
Yeah. Leaning forward is better, right, Brooke? Good. The other thing is you're elevating those feet, which means that all the fluid's returning to the heart. And whether it's right or left-sided congestive heart failure, you're overloading the heart, right? Because if it's right-sided, well, the heart can't pump it to begin with, so now you're overloading it. If it's left-sided, it's going to get all the way through the right side and then back up in the lungs. Like 3 more. I'm going to grab a soda real quick. I'll be right back. Okay, so good. At least we didn't pick the third answer. I appreciate that. All right, so first of all, if they're 4 weeks ago, what phase are they in? They're already in post-acute. They're already in post-acute, right? The main thing is when you see somebody that's out 4, 5, 6 weeks, the key phrase you want to look for in the answers is no changes in heart pain, chest pain, and no elevated STs could be as well, but we have ST segments on this one. I added them both. But the main thing is once they're about, say, 4 to 6 weeks out and is asking you which one of these is blah, 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 you're looking for no chest pain. Does that make sense? That's the key thing to kind of look for. No angina. It really, for the most part, it doesn't matter what the rest of it says. I mean, other than like deadlifting 500 pounds, you wouldn't want them doing that. That's probably going to cause angina. All right, we're a little bit all over the place on this one. So there's one of those I would have ruled out right away. And the one I would have ruled out is slowly performing EROM, because we're in phase 3. We should be out of that, right? That's the one I would have ruled out to begin with. The key thing with phase 3 is what can we begin?
Strength training?
Yes, strength training means resistive training. That's the key thing with phase 3. I mean, theoretically, running on a treadmill at 5 miles an hour, maybe if they've been previous beforehand, but like most cardiac patients didn't run to begin. Have you guys ever tried to walk on a treadmill at 2 miles an hour? It's ridiculously slow. It's just bad. I can't even, like, it's like, okay, I took a step. Now I'm just going to stand here for a few seconds until I take the next one. It's really slow. We normally walk about 3 to 4 miles per hour. All right, good. Most of you picked the right answer. I appreciate that. Seated with lower extremity in independent position, because all that's saying is they're in what position?
Tripod.
Tripod or short seated? They're in short seated for the most part, right? Their legs are down. What condition would that be contraindicated in? Or a precaution, probably, but contraindicated precaution. Right-sided heart failure. Because at that point, if they're all the way down, what's going to happen to their swelling of their legs? It's going to get worse, right? Especially if they're not using them, right? If you're just sitting there doing all their exercise and seated, all that fluid is just going to keep going right down to the legs. So we have to be careful with that. So we have to get them moving. It doesn't say anything about their lower extremities. But for this one, pulmonary edema, we want them upright, right? So upright is seated upright in a normal position. Any of this, if it had said seated in long sitting, that would have been a valid answer too. Does that make sense, guys? All right, let's see how we did.
Oh, babe, you're at number 2.
See? We're getting there. We're getting there. Not bad, guys. Let me get out of this stuff.
I feel like I did pretty good, honestly.
Yeah. And again, that's why we're working on this. Leaning forward is better, 100% bronchius. So all of this, you guys did really well this one. I mean, I was expecting kind of a rough one on this because I know that cardiac is rough, right? Cardiac is always the hard one. But then here's what I would think of if cardiac is really rough for me. That means that I need to make sure I'm nailing neuro and musculoskeletal. Because if cardiac is rough for me, then I need to make sure that I'm dead on the other 2 major sections. That makes sense? Because that way, if you don't get a question that cardio kills you on, you make it up for in the other 2. So just be aware that doesn't necessarily mean you have to be perfect at cardio. I certainly wasn't perfect at cardio. But as you kind of start studying and reviewing, if you're like, okay, this cardio I'm just not getting. Okay, study a little bit harder, but then also really hit your neuromusculoskeletal so that you make up for it. But yeah, overall, good job. Any questions today about whether you're studying, anything like that today? You guys feeling a little bit better? It's starting to come along, right? You're starting to pick up a little bit of steam at least. That it's, yeah, right. You're still Riley's never going to pick up steam. I've just given up asking her that. She's just going to keep. She's going to be like, she's going to be 2 days before. I didn't study enough.
Mr. McKeever?
Yeah.
I don't know if we have time today. Probably next time. Could we go over the postural drainage? Because I feel like I'm learning multiple different ways and just the words are getting confused in my head.
Let me see. Do I have a picture of that?
Like from the video,
yeah.
I understood from like what the guy was saying. And then when we were doing the review session with, I think her name was Elizabeth.
Mm-hmm.
It was just like something different. There was just like a few things off. I don't know. I don't know.
That's okay. Let me bring this up really quick here. There's not past my Zoom. So the point of postural drainage, right? Why do we put people in certain positions? Well, the reason we put them in certain positions is to put that lobe in a position where the fluid's draining out of it. Right. So the easiest way I can tell you to study postural drainage is to memorize the position of each of the lobes. Right. So on your right side, you have how many lobes?
3.
Okay. On the left side, we have 2. Right. So that means you've got to pay attention that on that right side, you're going to have an upper, a middle, and a lower. And then you've got to think of the way those bronchioles come out of those lobes. That's the way you learn positioning for postural drainage, right? Mm-hmm. If you can at least get the basics of where the lobes are, and you get a question on postural drainage and you quick draw the lungs, you can usually then pick the answer out of your answers by knowing where that lobe is. I mean, memorizing, so yes, memorize the main chart for that is this chart here. This is out of your rehab book, right? So this is the, if there's a question written, this is the chart they're going to use because this is straight out of Big Red, right? It's Big Red. I don't have the page number on me right now because I don't think I have a Big Red here. Yeah, I don't have a Big Red here. But it's right out of Big Red. It's under postural drainage in Big Red. But this is the chart that all the questions are written off of. I guarantee it because this is what we're told to write them off of. I like this chart because it shows you the way the bronchioles are, right? And so how do I get the fluid out of those bronchioles? But for the most part, again, if you can memorize this part at least and memorize where the lobes are, then you can think of, okay, well, if I'm in the right lower lobe, I'm down here, right? So that means I need to get the fluid going this way to get it out. Does that make sense?
Yeah.
So that means my head is going to have to be down, right? And my legs are going to have to be up, and I'm going to have to be lying on my left side somehow. Does that kind of make sense on how I did study for that?
That makes sense because I also have it in my head that it has to almost be like gravity assisted.
Yep, almost always is gravity assisted. Yeah.
And that helps me. I think last time we were talking about it. So apical is like the uppermost part of the upper lobe, and basilar is
The base.
lowest part of the lower lobe.
Yes.
Okay.
Yeah. So like if you go over here, upper lobe, singular segments, anterior basal segment, right? So now we're talking the lower lobe, right? In the bottom kind of base part of it, but on the front side. So they're not really going to go that, I'm going to be 100% honest, they're probably not going to go that specific into it. That they're asking you what position you put them in for the anterior basal segment. They're more going to talk in generalities about the lobes themselves. So if you were draining the lower lobe, which of the following positions, lower right lobe, which of the following positions would be most appropriate to put them in for? Does that make sense? Yes, if we're doing this, if you're working with kids with CF, yes, you have to know all these positions.
Okay.
Does that make sense? But for your boards, don't get, again, are you going to get a question on this? Maybe. This is probably going to be your 1 in, I don't know, 100 chance of getting this question on these. And for me, when I studied this, until I got out and worked with kids, it didn't make sense to me. Right? But what I did is I just majorly hit this and like, okay, if I'm in an upper lobe, well, I know my bronchioles kind of go like this. That means I need to be sitting up to get them to drain down into the bronchiole so I can cough them up, right? And the main goal is to get them into the main 2 bronchioles so that you can cough them out.
Okay.
Right?
So, and it's kind of like thinking towards our sternum, right?
Yes, yes, going to the sternum.
Okay.
Does that help you?
Yeah, I'm just gonna have to like get in the positions myself and try that.
Yeah.
Probably
and,
draw it too.
Yeah, draw it is the big one I did. When I was one of the things I did in my brain dump is I drew my lobes as soon as I sat down.
Okay.
Because that helped me. Then I could just looking at that picture helped me think about what position to put them in. Right.
Yeah, definitely. The
other thing you might get when you get a question like this is it might ask you, might say, you're performing postural drainage. What phase of ACVT is important to follow after postural drainage? And what phase is the most important after this? Phase what?
3.
3. Yeah. Because we can drain all that to the center lobes. If we don't get them coughing or huffing, all that's going to happen is the stuff's just going to settle back down in where they were.
Okay.
Does that make sense? Yeah. But if you kind of get the idea where the lobes are, that will help you.
Okay.
And again, that's not one I'm going to freak out 100% on, that I'm like, oh my God, I don't remember every lobe. I'm more worried about if it's, do I understand the lobes, right?
Okay.
Because that's going to help me in general.
Okay. Thank you.
Yeah, no problem. Any other questions today, guys? Feel a little better?
I just have a question about our homework from the final exam course.
Okay.
They said to watch the gait cycle as well. Is that the one that's included in the bonus content, or is that the separate one that's on our homepage?
Let me look, because I don't remember off the top of my head. Let me bring that up, because that's a really good question.
I'm kind of worried because we're going to start musculoskeletal and I'm still on cardio. I'm just trying to really understand the material before I move on.
That's fine. I mean, all that just means is that if that happens, that means you got to kind of pick it up a little bit then. So she talked about gait cycling. Let me go in here. Yes, so in the bonus content. Yes, down in the bonus content. I defined it. I knew I saw it. I just had to figure out where it was. Yes. And the only reason go ahead, I'm sorry.
Sorry, so it's not the one that's extra on our homepage. That's a like set of just gait videos.
Let me. Oh, the gait training, and yeah. I would just send her a telegram asking her that. Because she's still responding right now. She won't respond obviously on Monday when she's getting herself caught up, but just send her a message about it. I'm not sure which one of those it is. That's a really good question, and I don't have the most appropriate answer for that. Good question though. I'm going through it with you guys, just to let you know. So you're not the only ones doing this thing. And I guess I just watched them all and didn't really think about which to study. Yes, Brooke, that's not a problem. All right, any other questions? If not, good job today, guys. If there's anything specific you want me to cover next week, because I haven't gotten anything specific this week except for the waveforms that Brooke asked me about. If there's anything specific you want me to cover next week, just shoot me an email or a text or something like that, smoke signal. Don't send it to Telegram because I don't check that Telegram at all. I'm just saying I had to join Telegram because I don't even have a Telegram account. But yeah, ask questions, whatever you need. Other than that, get out of here. Enjoy your Friday. Let me stop recording real quick, Brooke. Hold on a second.